वालेकुम सर।
सलाम।
सर क्या हाल है?
बस ठीक ठाक, आप सुनाओ।
अल्हम्दुलिल्लाह सर, फर्स्ट क्लास।
आज अच्छा, इनका टॉपिक क्या है आज?
सर आज टॉपिक जो है ना वो है इनहेरिटेड मेटाबॉलिक डिसऑर्डर्स प्रेजेंट लाइक HIE।
अच्छा चलो ठीक है। ओके। चलो मैं अभी 2 मिनट, अभी मुझे इन द मिडिल ऑफ समथिंग, आई विल ज्वाइन अगेन, ओके।
श्योर 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 सर, श्योर।
एंड पुट मी एज ए पैनल तो आई कैन कंट्रोल माय म्यूट एंड
जी
दिस
जी
थिंग।
जी 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 सर।
ओके ओके।
वालेकुम सर।
अमेरिका इज नॉट कंसर्न्ड अबाउट दैट, मगर अमेरिका के इस बिहेवियर से सफरिंग तो बहुत ज्यादा हो रही है ना दुनिया में।
जी सलाम वालेकुम सर।
तुम लोग पता नहीं आप लोग के गर्ल्स स्कूल में होता था कि नहीं।
सर वो आई थिंक सर कहीं बिजी हैं।
स्पीकर अभी ज्वाइन हो गई बुशरा?
सर जी जी, बस मैडम जो है ना अभी उनके इन कांटेक्ट हूँ सर, तो अभी ज्वाइन कर रही हैं सर।
Still we have time, no need to rush, okay?
जी जी सर।
Hmm.
अस्सलाम वालेकुम मैडम। अस्सलाम वालेकुम मैडम।
वालेकुम सलाम। कैसे हो भाई?
जी जी मैडम, अल्हम्दुलिल्लाह। आप सुनाए कैसी हैं? ठीक है मैडम।
अल्हम्दुलिल्लाह।
मैडम वो स्क्रीन शेयर कर दीजिएगा, मैं यहाँ से अलो कर देता हूँ।
हाँ, वही मैं करने की कोशिश कर रही हूँ, मुझे कुछ
अभी हो
नजर
जाएगा।
नहीं आ
अभी अभी हो जाएगा मैडम।
रहा। ऊपर तो कुछ है ही नहीं, रिकॉर्डिंग वगैरह है।
स्क्रीन शेयर में मैडम, शेयर स्क्रीन में जो है
स्क्रीन
ना।
शेयर का कोई ऑप्शन नहीं नजर आ रहा भाई।
एक मिनट मैडम, अब देखें मैडम करके।
नहीं, वो जैसे ऊपर आता है ना, वो कुछ भी नहीं है।
नहीं मैडम, नीचे होगा, नीचे जो है ना। एक मिनट में आपको पेनलिस्ट कर रहा हूँ, अभी आई थिंक हो जाएगा। अब चेक करें मैडम।
अब आया।
हाँ मैडम, अब आ गया है।
अब आया।
जी जी मैडम। जी जी
जी
वही नजर आई।
जी 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 बिल्कुल मैडम, मैक्सिमाइज कर लीजिएगा, बिल्कुल नजर आ रही है।
सुनी जा रहा हूँ। अब चला, अब हो गया।
जी मैडम बिल्कुल।
चलो ग्रेट। अब इसको मैं मूव कर रही हूँ, देखो मूव हो रही है।
बिल्कुल बिल्कुल हो रही है मैडम वो।
सही है ना?
जी जी मैडम बिल्कुल।
बस ठीक है, फिर अब हम बैक कर लेते हैं। चलो गुड गुड। हो गया। तुम्हारे 8 o'clock पे आएंगे ना सारे बंदे?
जी मैडम, अभी
या आ गए?
प्रोफेसर खालिद हक एंड प्रोफेसर जुनैद मुहिब खान जो है, उन्होंने ज्वाइन कर लिया है हमारे अभी राइट नाउ। तो वो हैं हमारे साथ अभी, बाकी लोग जो हैं वो इंशाल्लाह 8 बजे हो
अच्छा
जाएंगे।
जी।
चलो।
अस्सलाम वालेकुम।
वालेकुम अस्सलाम, कैसे हैं सर?
बस अल्लाह का शुक्र है, आप सुनाओ बुशरा? ठीक ठाक।
अल्हम्दुलिल्लाह, मैं बिल्कुल ठीक हूँ। आप बताएं, कैसा
बस
चल रहा है काम?
काम हमारा काम तो बिजी रहता है। अब आप ये देख लें कि हम आई एम राइट नाउ ऑन हॉलीडेज बट स्टिल डूइंग दिस एंड मेनी अदर वेबिनार्स। तो अल्लाह का शुक्र है, इट्स वेरी नाइस। अपना सईद, इसको यूट्यूब पे और अपना की जो पीड्स है ना, उसमें आप सारे लेक्चर डालना शुरू करें, ठीक है?
सर अपना उसमें उसमें सर मैं नहीं हूँ, आप मुझे वो बता दें तो फिर उसमें
हाँ, वो मैं कर कर लूंगा जरा। लेट मी गो बैक टू माय ऑफिस इंशाल्लाह अर्ली सितंबर,
जी जी
एंड
सर।
देन आई विल कांटेक्ट यू।
श्योर श्योर सर।
If you say Khalid Haq, if you send it to me, I am member of that Apna group. I can put it on there.
या
श्योर सर।
बल्कि ये हो सकता है कि हाँ, सर को सारी आप वो जितनी भी हमारे प्रीवियस हैं उनकी रिकॉर्डिंग भेज दें एंड दे
जी
कैन
जी
पुट इट, बिकॉज
Yeah, I can put it, no problem.
sure. And the other thing is that क्योंकि it's new for Bushra, that not many people join at this time, but this is on YouTube and recording. So the people will, stay on their leisure. They will see the recording and everything. And if you kind enough make a PDF of your presentation and send it to the Saeed so we can share with the participants later on. Said, I think wait
sir.
just 1 or 2 minutes more, and then we
Sure.
can start. Then you
Sure,
can
sir.
start introduction of Bushra. Okay.
Sure, sir. Sure, sir.
सही मॉडरेट आप करोगे बीच में बिकॉज क्वेश्चंस जो आएंगे वो आप
जी जी
ले रहे होगे
जी जी मैडम, डॉक्टर जुनैद भी हैं, मैं भी हूँ।
अच्छा ओके फाइन
जी जी
बिकॉज लाइक व्हाट इज द फॉर्मेट आप लोग कैसे करना चाहते हो लाइक यू टेक क्वेश्चंस इन बिटवीन और यू वांट द क्वेश्चंस एट द एंड व्हाट इज द यूजुअल वे व्हाट डू यू प्रेफर
नहीं बुशरा, वी कैन टेक द क्वेश्चन इन द एंड, ठीक है। तो
ओके
अब बाकी जो लोग
ठीक
हैं
है
जिनको बीच में क्वेश्चन आंसर पूछने होते हैं, दे आर राइटिंग ऑन द Q&A पार्ट ऑफ
ओके
दिस ऐप, तो उसमें फिर बाद में सही तो वो क्वेश्चन पढ़ लेते हैं, देन एनी
सही है
पीपल, यहाँ तो वो आप आंसर कर दें, फिर उसके बाद हम में से कोई जो भी
ठीक
हैव सम क्यूरीज और डिस्कशन,
ओके
वी कैन डू दैट।
फेयर इनफ
सर, शुड वी स्टार्ट
श्योर
नाउ?
ओके, या यू कैन गो अहेड, या
मैडम स्टार्ट करें?
जी जी बिल्कुल
जी, thank you. Bismillahirrahmanirrahim. Thank you so much, everyone. Today, we are going to start our another webinars session on the neurological problem in the newborns, and it's a very important session today, which we are going to start, and it's inherited metabolic disorders presenting hypoxic ischemic encephalopathy. And today our speaker is Dr. Bushra Afroz, and she's associate professor and the consultant clinical biochemical and the clinical genetist in the pediatrics and child health department, Yahya Khan University Hospital, Karachi. And she's the first physician in the Pakistan having the specialization in the metabolic and the genetic disorders. And she's only formally trained clinical biochemical genetist in the Pakistan, and she has over 45 publications in the field of the clinical genetist and inherited metabolic disorders. In addition to her clinical work, she works closely with the Department of the Pathology and Laboratory Medicine as an expert advisor and is involved in the planning and the strengthening of the laboratory biochemical test menu. And test menu. And she is dedicated to educating the healthcare provider partners for the providing care for the genetic disorder. She is actively involved in the guiding physicians across the country to cater to the unique need of the patients with inherited metabolic disorder. As a part of the improving physician awareness is about this orphan group of the disorders, she's regularly delivering the lectures and holding the workshops on the genetics and metabolic disorders at different platforms. And even though recently, in last month, one workshop was held in at Islamabad regarding the metabolic disorders. And today, another topic we are going to discuss. So over to you, madam. Thank you.
Okay, thank you, Said, and thank you, the organizing team, to provide me this opportunity to talk about this important topic. And I believe most of the participants are in the field of neonatology. So when Said approached me and wanted something on the inherited metabolic disorders, I thought that in context to in relevance to the neonatology group, it would be nice if we can discuss something which is often the neonatology which people see, which is the hypoxic ischemic encephalopathy. And as you all know that I'm a metabolic physician, so it happens that a number of inherited metabolic disorders tend to present with initial presentations mimicking like the HIE. So when I am unable to, okay, so this is how we are going to move today. We will review together the IMDs that may present like the HIE, and how do we approach the IMDs which can present as HIE. And then in the end, I will share 4 real patients, real cases who were labeled initially as HIE and then eventually turned out to have one of the IMDs. So I don't have any conflict of interest to declare. And Pakistan is actually occupies the global spot for the highest neonatal mortality in the world. And I don't need to tell you that the neonatal mortality rate in this country is very high, and we have been struggling as a nation to bring it down for the last almost over 2 decades. What we are told and what we are taught by agencies like WHO and UNICEF, that the children in this country, the young children under 1 month and under 5 years of age, and are dying because of conditions like the birth asphyxia, stillbirth, sepsis, pneumonia, diarrhea, and birth defects. Why am I bringing this subject in context to the IMDs presenting as HIE is because of a fact that over the last 2 decades, despite pretty serious efforts taken by the government of Pakistan in collaboration with WHO and UNICEF, and by improving the safe birth of babies, taking care of the mothers during pregnancies, increasing the number of the trained birth attendants, and decreasing making the birth process as safe as possible, has been there. Whether we admit it or not, but the efforts by the government and the agencies are there. But despite all these efforts, we have not been able to bring down the neonatal mortality rate over the past 2 decades, as we had anticipated that it should come down. And it is not just a surprising fact, because it has been seen in the developed part of the world that once all these measures are controlled, are taken better care of, the other conditions which are the genetic as well as the non-communicable causes of diseases have taken over on the infant of the mortality rates of the children, as well as the morbidity, increasing the morbidity rates. So why is this important, and especially in the Pakistani context, is because the inherited metabolic disorders, most of the IMDs tend to have autosomal recessive mode of inheritance. And as you all know, that autosomal recessive disorders are more prevalent in communities with high rates of consanguinity, and Pakistan has on the national report of the consanguinity rate for Pakistan is about 2/3 of the population is consanguineous, is married to has a consanguineous union. So what are we missing? Like I said, the HIE is a condition, is a manifestation which we all have been taught in our med school as a resident, as trainees. And we know that there are certain parameters at birth which are taken into consideration. And when those parameters fulfill certain criteria, which we label as a baby according to the APGAR scores, depending on the heart rate, the respiratory efforts, the tone of the babies, the overall activity of the baby, and different things like skin color, we tend to label something as called as birth asphyxia or hypoxemic encephalopathy. Biochemically, ideally, the blood and the cord blood pH less than 7 is highly suggestive of HIE. The perinatal asphyxia thing is about 10-fold more common in the developing country than in the developed country. And 1/3 of neonatal mortality is attributed because of HIE. And I think why am I bringing this basic concept of HIE? Because HIE is not new. It is for me as a metabolic physician, it is actually the egg or the chicken first. Is the HIE the primary phenomena, or HIE the secondary phenomena of an underlying disorder which has resulted into HIE? So the HIE, I have learned from my colleagues in neonatology that obviously they tend to monitor and screen certain parameters for the liver, the kidneys, and different biochemical parameters, and constellation of all those signs and symptoms and biochemical parameters resulting into systemic complications of HIE helps them to label certain babies with HIE. And then the inherited, linking it to the inherited metabolic disorders. Inherited metabolic disorders mostly are these are progressive disorders, mostly progressive disorders, and inherited. Most of them are autosomal recessive, but there are certain other modes of inheritance as well. And since the autosomal recessive disorders are more common in the consanguineous community, so we are not investigating the babies who are labeled as HIE. A lot of times, actually, we don't even have FGARs at birth. We hardly ever have the cord blood pH available, and all what we have is a history of poor cry, and then certain biochemical parameters, involvement of systemic complication, compelling the physician to label the child as HIE. Whereas the metabolic disorders which present as HIE is much more complex. And metabolic disorders are collectively not, like, they are individually rare, but collectively not as rare as we may think of them. Especially in communities with high consanguinity rates, they may not be very rare. And in our country, over the last over around 15 years of my experience, I've seen many children with very rare disorders, and we have been able to some of the disorders, even total global reported cases, we have about 1/3 of the total global reported cases available present in this country. So any condition in the biochemical pathway resulting into the defect of resulting into the defect of a biochemical pathway results into a disorder, and is labeled under the inherited metabolic disorders. Like I said, that inherited metabolic disorders are progressive and disorders mostly inherited, and more than 1,400 IMDs are known. And when we have this large number of disorders in any discipline, the age of presentation also is spread widely. Inherited metabolic disorders can start presenting in utero till very old age. Whereas in the newborns, around 1 in 800 newborns is said to be affected by any of the inherited metabolic disorders. And a number of IMDs can present like HIE-like presentation. Common clinical signs, clinical phenotypes presenting as HIE these are some common clinical phenotypes which can present as HIE. They may have isolated seizures, severe metabolic acidosis, encephalopathy or lethargy without acidosis, or with hyperammonemia, and significant lactic acidosis with hypotonia. These are broad phenoclinical phenotypes. When we have any of these clinical phenotypes, the likelihood of the HIE secondary to IMD is high on the cards. And when, like I said, the number of the disorders are huge, more than 1,400 disorders. I'm going to just, this is a busy slide, but I don't think that anyone can remember all these complex names. But just these basic clinical phenotypes, which we have just seen in the last slide, you can see that just isolated seizures, non-ketotic hyperglycemia, molybdenum cofactor deficiency, pyridoxine responsive seizures, folinic acid responsive seizures, a number of neurotransmitter defects, paroxysmal disorders, certain organic acidemias, mitochondrial disorders, they can all present as isolated seizures in newborns. And when it comes to the severe metabolic acidosis, mostly the organic acidemias tend to have this clinical phenotype. But these are some of the metabolic disorders which can have and which can come under these separate clinical phenotypes. And how do we approach these when we are considering IMD in a baby who has HIE? Then how do we approach these children, and in the form of their laboratory evaluation? There are certain basic laboratory investigations which are shown in this slide, and these are the ones which I think all physicians working in the neonatal care area needs to be aware of, and these are the labs which should be done in all the babies in whom the HIE is considered. And whether you have considered IMG as a cause of HIE doesn't matter. All these labs needs to be done in all the babies who are labeled as HIE. And then there are certain labs which you may call as the second tier testing. If you are confident enough, you can do all these second tier testings as well. But not all babies need all of these second tier testing. And here, for the second tier testing, if you have a good clinical judgment, and if you have the access to a metabolic specialist, it would be nice to have that discussion and then titrate and select the most appropriate second tier testing for your babies. The routine testing, like the full blood count, the urine DR, the electrolytes, the renal functions, liver enzymes, uric acid, creatinine, blood gas, then the CSF for the routine detailed report, as well as the cultures of the blood and the urine. These are some labs which I think most often, a lot of these are already done. The basic metabolic investigations are done sometimes, but not always. Did you lose my presentation?
जी जी मैडम,
आप लोगों को नजर आ रही है?
जी जी बिल्कुल मैडम, मैक्सिमाइज कर लें। जी जी।
अच्छा। So the basic metabolic investigations, what I have observed that these are sometimes done, but not always. And when I see that these are done. Not all of these are done. So, but the basic metabolic investigations in HIE patients, I think these are these like ammonia, lactate, pyruvate. If you have excess, we don't have pyruvate available. The plasma amino acids, the quantitative one, and the urine organic acids. Total and free carnitine, as well as the plasma acyl carnitines. These are these should be done, and I don't think that specialist consult is required to get all these done. But when it comes to the advanced, the second tier metabolic investigations, like when should you get the very long chain fatty acid, phytanic acids done? When should you get the neurotransmitters done? Should you go for the urinary ketone, urinary creatinine and guanidoacetate levels assessed? Do you need urine purine pyrimidine? Because these are all pretty expensive and not mostly available. We are also, most of these labs, the second tier tests, we need to outsource at present. So I think it is nice to have a discussion and then select the most appropriate investigations for a baby. And the DNA extraction, meaning saving some DNA in a sick baby, may be helpful for the future reproductive options and for making a definitive diagnosis at a molecular level. But you need to have a consent and written down in the medical record that you have the consent for the DNA banking or the DNA extraction for that particular baby. DNA banking has become quite in fashion these days in Pakistan, but I think the seriousness of DNA banking or DNA extraction or saving DNA in a baby in whom we do not know how will we use the DNA is a serious matter and should be done after taking consent from the parents and the guardians. I am moving on to the real life cases, I think, which actually is the most important part of today's talk, and which makes my claim more solid, that these are the 4 children who were admitted at our hospital and were initially labeled as HIE, and then eventually, for some reason, the metabolic team got involved, and all these 4 children turned out to have one of the underlying metabolic disorder. So the case number 1 was a boy. He was born after an uneventful pregnancy at term, and was noted to have suckling and excessive cry. It was jittery by day 1 of life, and so he developed frank seizures on day 2 of life. He was admitted and then was labeled as HIE. So, like I said, EBGARs, I have hardly seen, very rarely EBGARs are available, especially for the babies who are not born at a good center. So and like I said, and you are all aware that consanguinity is quite common in our part of the world. So parents of this baby was also consanguineous. Interestingly, there was a history of death of a SIB with a very similar clinical presentation. And then this was the background history. I got involved for this baby at around 2.5 months of age. And at that time, he had a global developmental delay, was significantly hypotonic. On the review of his biochemical labs, his ammonia levels were normal, the lactates were normal. And the one thing which was quite persistent, and it was done 2-3 times, was the serum uric acid, which was persistently low in this baby. The plasma amino acid was not done by the time when he reached in the clinic, and when it was done, it showed methionine, which was elevated for his age, serum plasma taurine levels, which was also elevated for his age, and plasma cysteine, which was very low. Remember, cysteine is also an amino acid which which can have very low values because of prolonged storage of the plasma sample, which results into the depletion of the cysteine levels in the plasma. But this child, hyperuricemia with hypermethionemia and raised taurine levels, along with cysteine, the possibility of cysteine as low cysteine because of the prolonged storage was remote, but rather this very specific combination where I think the serum uric acid was the marker, was the lead for me to think of the diagnosis in the lines of the molybdenum cofactor deficiency, which is a purine metabolic disorder. And I then went for the plasma amino acid first, and I got this results, which was very classic for the disease. And he already had this brain MRI image available. Rather, he had actually 2 brain MRI images. And the first one and the second one, this is the second one actually, which shows cystic encephalomalacia, and very large, very impressive cystic changes, which is again very consistent with the clinical suspicion of molybdenum cofactor deficiency. And then this is the second tier test which I was talking about, where I got the urine purines done, and it showed again a very classical pattern of urinary sulfocysteine, which was raised, urinary xanthine, which was raised, and urinary hypoxanthine, which was raised. All these biochemical markers are highly suggestive of molybdenum cofactor deficiency, which is an autosomal recessive disorder, and it is characterized by neonatal onset encephalopathy, which is by textbook literature is a HIE mimicker. If these children survive, it has a very grave prognosis. Then they have intractable seizures. They have feeding difficulties and respiratory difficulties. And this is the biochemical pathway, which if you can see, the molybdenum cofactor, it has it can have 3 enzymes: sulfide oxidase, and then xanthine oxidase deficiency, and both of these combined can cause the molybdenum cofactor deficiency. And when it is blocked, when it is not functioning properly, your xanthine and hypoxanthine is elevated, as was seen in this patient. The sulfocysteine is elevated, as was seen in this patient. Taurine is elevated, as was seen in this patient. And the uric acid is low, which was also seen in this patient. So a little knowledge about the biochemical pathway helps in understanding what we are getting. but I believe that uric acid is a very excellent marker, is a great marker for screening of molybdenum cofactor deficiency in a baby, in any child, especially a young child who presents with a HIE-like presentation. There are three different types of this disorder, type A, type B, and type C. Type A is caused, these are all caused by three different genes. And type A is the most common one. Unfortunately, this family did not opt for the molecular testing, so I was unable to make a definitive subgrouping of the types of the molybdenum cofactor in this particular baby, but the biochemical parameters, the clinical presentation, the brain MRI findings are all very suggestive of the molybdenum cofactor deficiency, and it presented like HIE. The child was labeled as HIE, but the eventual diagnosis opened up the possibilities of future testing for their future pregnancies. And then this is the second child who was detected to have a hydrocephalus on the fetal ultrasound. She was born hypotonic and was noted to have grunting, was labeled as HIE. Parents were again consanguineous. The death was also there for in a SIP with very similar clinical presentation with no diagnosis. She had her biomarkers done for as a part of HIE screen, which were all raised, the lactate, ammonia, creatinine, LDH, and the CPK. And this child was also, the primary neonatology team had also done the plasma amino acid for this baby, which was also very classic for a disorder. And it had a citrulline level which was raised, the lysine which was raised, and the glutamine which was low. And then this is the brain MRI for this child. And if you are able to appreciate, there are some cystic changes in the subependymal region. And then there is some enlargement of the lateral ventricles of the lateral horns of the ventricles, fourth ventricles, and then there is some degree of this was a term baby. There was this was a delayed, not age appropriate myelination for what we expect in a term baby. And this brain MRI, along with the plasma amino acid, with the clinical presentation, was suggestive of the lactate in this baby. If I may go back, the lactate in this baby was pretty high. It was very high in this baby, and this child was born at AKU. We had the opportunity to get his molecular testing, targeted molecular testing done for the pyruvate carboxylase gene. And this baby was found to have a homozygous deletion of two base pairs in the pyruvate carboxylase gene. It is an autosomal recessive disorder which involves the pyruvate metabolism and characterized by the CNS symptoms as well as significant hyperlactic acidemia. There are three different types. The neonatal type is actually the type B, and it is the most severe type, which present as HIE and has severe lactic acidosis, and the lactate pyruvate ratios are also elevated, hyperammonemia and hypercitrullinemia. And if you remember, this big baby had a citrulline level of 150, which was elevated for his age. There are two other types, which are milder types, and the neonatal form usually do not survive beyond early infancy, whereas the type A, which is the infantile onset, and the milder type, which presents beyond infancy, these babies tend to survive, but their overall outcome is not really very promising. And then the third case is again a boy. He was born at term and he was in an IUGR baby and was born through an elective lower segment cesarean section. He was noted to have hypotonia post-sucking after birth and was labeled as HIE. I think the third point in all these three babies are very similar, which is not new. We often see these presentations repeatedly occurring in the families, and it is strange. I think a physician should think that why is HIE happening again and again in a family? HIE should not happen again and again in the family. And all these three babies had a history of a sick death with similar presentations with no diagnosis. This is the clinical picture of this child, and I hope you are able to appreciate that he is appearing significantly hypotonic, very elongated face, and a very prominent forehead and wide apart eyes. This is a very and I don't think one can appreciate, but he also had a very large anterior fontanelle for his age, a very large open anterior fontanelle for a term baby. And then when we saw this significant hypotonic babies presenting as HIE with a family history and the very large anterior fontanelle, we got this babygram. And if you are able to appreciate, just focus on the kneecap of this baby, which is the baby is lying obviously in this skeletal survey, the frog-like posture. But for term babies, usually we don't see the kneecap on the X-rays because those are not ossified not calcified at this time. But because of the disorder, what is actually happening here? It is a calcification which gives present at birth, and this is a very important clue for a disorder which comes under the Zellweger spectrum. And the Zellweger spectrum babies tend to have some degree of polymicrogyri, which may or may not be present, but this baby's brain MRI also showed polymicrogyri. And based on the clinical presentation, the brain MRI, the calcified patella, as well as the significant hypotonia, large anterior fontanelle, we got the targeted second-tier test, which was the very long-chain fatty acids, and it was significantly elevated, which the diagnosis was further confirmed by the molecular testing of the PEX1 gene. Actually, we got the whole next generation sequencing for the paroxysmal disorder in this baby, and he was found to have the PEX1 mutation, and which is one of the most common genes involved in the Zellweger spectrum. Zellweger is a paroxysmal biogenic disorder, and there are 13 different genes. PEX1 is the most common gene involved in this large group of disorder, and the disease severity also varies, and it has a wide age of presentation. The neonatal forms are the most severe forms, but you can have the later age onset. The childhood onset is somewhere, and they survive, but they have significant morbidities and challenges in their life. Whereas the adult onset have different type of clinical manifestations. Mostly they present with cerebellar signs as well as the neuropathies, sometimes white matter changes resulting into gait problems, again via the neuropathy change, the neuropathies and all those things. But when we have the Zellweger spectrum presenting in the newborn time, then they hardly survive beyond the first few months of their life. The last case was a girl, and the mother reported decreased fetal movements and a non-progressive labor resulting into an emergency lower segment cesarean section. She was hypotonic, had seizures, and on day 2 of life, and then she was also labeled as HIE. This child also had a history of death of a sibling with the similar clinical presentation. The biomarkers, which is usually done in the HIE diagnosis, were also raised, but here the lactate was not raised as what we saw in the pyruvate carboxylase deficiency patient. And because of this child was actually having bad seizures, like iske seizures control ही नहीं होते थे, तो वो जो EEG हुआ था, I'm not an expert in this area, but I'm told that this pattern is what is called as the burst suppression pattern. And this is a lot of times in our setting, instead of the brain MRI, because the bedside fetal ultrasound, head ultrasound is done. And here, what is seen was the agenesis of corpus callosum. So agenesis of corpus callosum, decreased fetal movements in utero, see early onsets in seizures which are not responding to the anticonvulsants with burst suppression, is a very suggestive clue for the disorder which is called as the non-ketotic hyperglycemia, for which a paired CSF and the plasma glycine levels are needed to calculate the ratio, and ideally the ratio is less than 0.02, and for this particular baby it was 0.24. However, I would caution my colleagues here that the CSF glycine levels will be elevated if the CSF is what is called as a traumatic CSF. If there are blood cells in the CSF, because the procedure was done and was traumatic, then you will have a false elevated plasma CSF glycine, but you will still not have the plasma glycine which is elevated. And this glycine, the non-ketotic hyperglycemia is a whole cleavage. It has 4 proteins, which is the H, P, and L and T proteins, and these are all coded by different genes. And the characteristic of this is the plasma glycine, which is very high. Therefore, it is called as hyperglycemia. And non-ketotic hyperglycemia is a word attached to hyperglycemia to differentiate it from the ketotic hyperglycemia, which in the olden days was the name given to the disorders like the propionic acidemia, where we also have significant plasma levels, elevated levels of glycine. But in the propionic acidemia, the ketosis is also present. Therefore, it is called as ketotic hyperglycemia. And then this hyperglycemia, for the secondary to the NKH, was differentiated from the propionic hyperglycemia by attaching the word of non-ketotic hyperglycemia. And like I said, it has 4 different proteins, and this is the majority of the patients tend to have the defect in the P protein, which is the most common one, whereas the T and the H protein are also there, and the L protein is very, very rare. The outcome of this clinical condition is based on the two different types: the severe, or what was also called as classical NKH, and then there is an attenuated NKH. The neonatal presentation is mostly the classical NKH, where the prognosis is really bad, and these children mostly succumb to their illness during the first year of life. Only, it is said, as per the literature, only 1/3 of the patients survive beyond the first year of life, and those who survive have severe developmental delays and very, very bad epilepsies. Where, however, the attenuated form can have a variable development, and somewhere they may have very mild developmental delays, but they are also but the seizures are not as bad responsive to anticonvulsants as the classical or the severe NKH patients are. And I found this paper very interesting when I was reviewing my literature a couple of years back, to when I was compiling these 4 patients, and I came across this nice paper which was published in 2014, and it has very nicely summarized in one of the last paragraphs of its this paper, and it says that if a comprehensive etiological evaluation is not possible, the term hypoxic ischemic encephalopathy should best be replaced by neonatal encephalopathy, because neither hypoxia nor ischemia can be assumed to have been the unique initiating causal mechanism. And I believe this is very true for the 4 cases which I have presented. And after these 4 cases, we all have seen patients. I've been a metabolic physician. I come across in the patients who are labeled as HIE, and then eventually when they are investigated, not all of them, of course, but some of them tend to develop, are diagnosed to have an HIE, and this makes a hell of a difference. Complete different approach for their parents and their families to plan their future pregnancies, and not just because once you have a diagnosis, especially at a molecular level, you can offer them future reproductive options. So my take home is. And this is the paper which I published in I think 2018 or 19, and it has summarized all the 4 cases. Now for the juniors, for the trainees, I would refer them to this paper. Please read this. There are many references on this paper. It is a nice summary and a clinical presentation of the HIE presenting as IMD presenting as HIE. And I think I will stop here, and I have kept it short intentionally so that I can take more questions and we can have a mutual fruitful discussion. Thank you very much.
Thank you so much, madam. I think it was a very interesting presentation. Any question from house? Most welcome. I think, madam, a question है. Is carnitine profile available in AKU lab?
So, if I'm correct in understanding by the carnitine profile, are you asking Dr. Yasser Mansood about the total and the free carnitine, or am I correct in understanding if you are asking about total plasma, total carnitine and plasma free carnitine? Because plasma, total and free carnitine is still not available in AKU or anywhere in Pakistan. But the dried blood spot for the acyl carnitine, you can have the total carnitine as reported as C0, which is there, which you can see. But the dried blood spots for the C0 is only for the values are validated only for the newborn age. So you need to be very cautious if you are using it beyond neonatal age. So yes, Dr. Yasser said total carnitine.
Yes.
The total carnitine you can see on the dried blood spot, acyl carnitine, but like I said, the validation of that value is the cutoff of the validation for that value is only for the neonatal age. So if you are using it beyond neonatal age, then you have to be cautious.
Right.
And getting total free carnitine alone is not going to be very helpful, because for the disorders where you have the carnitine defects, like the carnitine transporter defects, then we actually tend to calculate, we need to calculate the fractional excretion of carnitine, for which you need plasma in the urine, total and free carnitine both. So which is not possible at right now.
Right, madam. Madam, Dr. Makbul is also want to say something. Ji, sir, can you hear me?
Yes, I can hear you. Can you hear me?
Ji, sir.
Yes, Dr. Makbul.
Assalamu alaikum, Bushra.
Wa alaikum assalam.
I hope you remember me.
Yes, of course I remember you. How are you?
Alhamdulillah, fine. Thank you very much for a very nice talk. I was afraid, this metabolic and genetic, and, always run away from these type of sophisticated type of talks, but you made it very interesting for us being neonatologists. Just wondering, these 4 cases, they were born in AKU or they were referred from other places?
The patient number 1 was not born in AKU, which was the patient number 1 was the molybdenum cofactor deficiency. He was not an AKU born baby. The patient number 2 was, I think, pyruvate carboxylase was AKU born baby. Actually, the patient number 2 was followed during pregnancy at AKU and then was born at AKU. And then the third one was the third one was what?
That one was Elviger.
The third one, the Zellweger, was followed during pregnancy. The pyruvate carboxylase one was also followed during pregnancy and then born at AKU. And then the last one was NKH. NKH was a referred patient. Came on day 3 or day 2 or somewhere around after the seizures, when the seizures were not controlled.
So if you calculate the incidence of HIE in AKU born babies, because you mentioned 1 in 800 newborns may present as IMDs.
Yes.
So if you look at the data, do you have a data from AKU that how many babies were born? They are like 5,000, 6,000 deliveries per year now, or?
जी बिल्कुल वो लेकिन सर उसमें जो है ना प्रॉब्लम क्या है प्रॉब्लम ये है कि वो जो 1 in 800 babies are born with an IMD is a number for when these babies are investigated thoroughly for all IMDs. So the babies who are born at AKU, as you know, they are born at AKU, but they are not followed for even for the first year of life at AKU. So even if the AKU born babies, if they have a problem in future, they are we don't know what they investigated. Even the babies who are followed at AKU, a lot of time they are not investigated. So these are the numbers when you have a very robust kind of system is in place, when the referrals are in place, when the symptoms are suggestive, all the needed disciplines get involved, you have the facilities available. So हमारे पास बहुत सारी चीजें available भी नहीं है, लेकिन जो चीजें available भी हैं वो भी बहुत ज्यादा जिस तरह से यूज होनी चाहिए वो अभी तक हुई नहीं है. We have achieved a lot, but we still need to achieve a lot more.
Yeah, exactly. Can I ask another question? If Saeed, do you have other questions lined up?
Sure. आप सर continue करें सर.
Side question, apart from this, your talk, you started newborn screening, right?
जी बिल्कुल अल्हम्दुलिल्लाह.
ये सिर्फ कराची में स्टार्ट हुई है या
सर इस वक्त जो है हमने we have the LCMS-MS, so like you know on the LCMS-MS we can screen. Well, actually we have both spectrophlorometer as well as this the LCMS-MS. So using these two equipments or methodology, we can screen as many as 51, not 51, rather 48 inherited metabolic disorders. But the newborn screening selection of which disorder needs to be included in the newborn screening panel has a very as a laid down parameter, and based on that parameters being ethically correct, we have opted to select only 12 disorders in our phase 1 for the newborn screening, and we are starting off. We have already started off at the main campus, and gradually we will go in the 3 secondary hospitals in Karachi and then 1 secondary hospital in Hyderabad. So this is
so as of now, this is only limited to AKU born babies, right?
देखिए sir, as if anyone wants तो lab के पास तो access, lab के पास sample तो आ जाएगा, लेकिन वो फिर वो मतलब ये कि हमारे यहाँ थोड़ा सा जो मुझे issue आता है वो ये कि physicians as well as parents tend to forget that this is a newborn screening. And a newborn screening is done in a baby who's well.
Yeah.
Is neither sick, you are not considering a metabolic disorder, and who does not has a family history of suggestive of an inherited metabolic disorder. So once you have a sick baby in which in whom you are considering a metabolic disorder, or where you have a family history where based on which you are considering possibility of metabolic disorder, then that baby is not a very good candidate for newborn screening. Then that baby is a candidate, becomes a candidate for a high risk screening, which needs to be according to your basic clinical suspicion. And a lot of time, the newborn screening, these all acyl carnitines, which are done on the LCMS-MS, as well as the different tests, which is like the biotinidase assays, which is done on the spectrophlorometer. These are validated for only newborn age. People just forget these basics things, and then every baby or every patient of whatever age with high index of suspicion, people are considering. I've even seen कि वो gene testing भी होती है, फिर भी उसके बाद जो है वो newborn screening test भेज रहे होते हैं. तो मैं पता नहीं, मुझे समझ नहीं आती कि आप दोबारा क्यों करें. मतलब जब आपके पास gene test हुई है, तो then why are you going back to square one?
The problem, Bushra, is there in Pakistan that the newborn screening is a new thing, and the people don't have enough education about that. I know in some, I don't know if in Akhan, I hope you are not forcing, because they have to pay, and there's a hefty amount they have to pay. For I don't want to do the newborn screening in my baby who delivered in Pakistan. The reason is not that I cannot pay, but the thing is that what is the next step after? There is a question right now that even if you don't have the ammonia, then how you proceed? So this is the real situation there. Regarding your talk, I have 2-3 couple of questions. First thing, Bushra, you are very skeptical about APGAR. You said there is no APGAR or real APGAR you are getting. What is about that? The people are not.
I'm not saying that I don't. What I meant was that APGAR scores are often at when the babies are received. It's not available for us to review. What was the APGAR at birth?
Okay. So why it is not available? Because if they label these babies as HIE, the APGAR is one of the major criteria to look into it. So tell your colleagues to before that please look into it. The second question is that you, I mean not you, that the patient admitted as HIE. So you said that at 2 months of age you involved. Why so late when the suspicion is high, when the one kid is die? Because
वो exactly ये वो जो है ना उसकी हिस्ट्री पे मुझे ये मिला था कि जो नहीं होते लाइक हमारे यहाँ जो फिजिशियंस की आउट पेशेंट प्रिस्क्रिप्शंस होती हैं उसमें साइड में वो थोड़े छोटे छोटे से नोट्स लिखे हुए होते हैं, उसमें उन्होंने कहीं लिखा हुआ था HIE 2-3 जगह मुझे ये लिखा हुआ मिला. फिर जो वो पेरेंट्स थे उनको भी उनसे उनकी ये हिस्ट्री थी, ये क्लिनिक में आए थे, उन्होंने भी ये बताया कि जो है वो हमें बच्चा रोया नहीं था और हमारा पहला बच्चे के साथ भी यही हुआ था. तो वो मेरे पास खुद आए थे, वो रेफर नहीं हुए थे कहीं से.
So this is the major problem, Bushra, and this is I think I'm not giving you a hard task, but this is your responsibility to educate your colleagues, okay, that what is the meaning of that. Early referral is better. Somebody, documentation is extremely important. Somebody, as you said, put HIE, and nobody told you that this is the sibling has the same problem. So I think this is one of the big thing before we go into the discussion of the treating the babies and what to do, which is obviously not available. But you are explaining everything very nicely. But I think they have to be educated on full history. Even they didn't take the history that the parents are telling you that our baby is one die. Even in the normal full-term baby, you have to ask this thing as a sibling. Is a third-year basic medical question. We fail on that in OSCE if they don't ask this question about the previous baby. So that's why I am very much, like in a sort of shock that how they can do that. Come back to your talk. I'm just taking too much time. Just one or two more questions. That what Dr. Sitara is asking. What is your opinion that let's say we don't have that much test, but we have suspicion of this metabolic disease as high on clinical background, on history. So what do you think that those facilities should do? They should refer to you, and do you have any, what you call charity or something that you can investigate, or what is the next step? Or they just say, sorry, we cannot do anything?
सर उसमें मैंने आपको जो लास्ट स्लाइड दिखाई थी referring to the paper in which it was, that is the reason I shared those lines, quoted lines from that article, was the precise reason that if they have nicely summarized, and I tend to agree with what the authors have written, that if you are not able to find a reason for in a patient for the HIE or the perinatal asphyxia, then at least don't use the terminology hypoxic ischemic encephalopathy. Label the child as neonatal encephalopathy, and then those are the babies who are the candidates for investigations. And what is happening in Pakistan right now, actually, a lot of people have the access. Even if small hospitals have access to ammonia. You said ammonia is not available. Ammonia is, I think, available right and left in this country right now. The urine organic acids or plasma amino acids, everyone is doing ammonia, the organic acids and amino acids. Everyone is doing all these basic biochemistry. Which is all these patients, the 4 patients I have shared, they have all of them have clues in the basic biochemistry, the hypouricemia, the significant raised lactate, the plasma amino acid patterns, which were suggestive of a specific disorder. Those things are there, but what I think is happening is that people are doing things, but they are unable to link the things together. And obviously, not all patients can come to AKU, but at least we can develop the culture of picking up the phone and discussing with each other. Not all patients need to come to AKU. If you have the laboratory labs available, just pick up the phone, discuss, and then maybe we can reach to a better conclusion together.
Sure. This is very important, and I think that in this thing, and I appreciate always these type of webinars what Saeed is conducting over the period of time, that people should educate, and they should attend, and they should learn from all these experiences. Okay, Saeed, over to you.
Sir, Dr. Yasser Masood is want to say something. Sir, can you hear me?
Yes, I can hear you, Said. Thank you, Dr. Bushra. Thank you for a very nice talk. My name is Dr. Yasser Masood, and I practice neonatology in Shifa International Hospital, Islamabad. And you were rightly said that there will be cases of HIE who actually would be inherited metabolic disorders. We get lots and lots of cases from KPK and even across the border from Afghanistan. Now, my question is slightly outside the neonatal age. Say, for example, we have got 6-month-old or a year-old babies who have presented in metabolic crisis. And as you mentioned, some of the basic biochemical investigations that we can do, like ammonia, lactate, blood gas, plasma amino acid, urine organic acid. So these are the basic investigations, uric acid and lactate, that we can do. And in Pakistan, some of these, obviously, they go to AKU, like organic acid and amino acid. Now, say, for example, a child has presented in a metabolic crisis who has been stabilized in intensive care, but these basic biochemical metabolic investigations have not revealed a diagnosis. Now, my next question is that at this point, obviously, we have to go for genetic testing. So what will be your approach in these babies who are not in the neonatal age? So they probably don't have some serious inherited metabolic disorder. They have something which is not as lethal as it would have been presented in the neonatal period. So a 1-year-old child presenting with metabolic crisis gets better with IV fluids. Initial presentation may be severe metabolic acidosis, but initial metabolic testing has not revealed a diagnosis. So now the next step is possibly genetic testing.
What do you mean by initial metabolic test has not revealed? What metabolic test has not revealed?
Just severe metabolic acidosis, but nothing else. So ammonia is
Nothing
normal.
else, including what? How far do you investigate those children?
So the initial, obviously we can do the lactate, ammonia, plasma amino acid, urine organic acid, uric acid.
So the timing of the plasma amino acids and the urine organic acids are very crucial.
Yeah,
so if you are doing those urine organic acids and the plasma amino acids beyond the metabolic crisis, even if you have once you have started your
I'm talking about
therapy, then
send at the time of admission.
These biomarkers will disappear and will not give you a diagnosis.
No,
so a lot of time you are very specifically saying metabolic crisis, and
yes.
you are very specifically saying metabolic acidosis. So
yes,
the metabolic crisis secondary to metabolic acidosis, that's a whole separate talk, and I have not covered it at all. But in the real world, what happens कि जो ये metabolic crisis जो हमारे यहाँ word use किया जाता है, इसकी भी 3-4 clinical main groups हैं. एक होता है जिसको हम metabolic crisis के अंदर जिसमें मतलब वो होती है वो मेटाबॉलिक इंसेफेलोपैथी जो कि इंटॉक्सिकेशन ग्रुप के साथ होती है. फिर एक होती है एनर्जी मेटाबॉलिक डिफेक्ट्स एंड जो माइटोकॉन्ड्रियल डिसऑर्डर्स होते हैं वो भी मेटाबॉलिक क्राइसिस और मेटाबॉलिक एसिडोसिस देते हैं. ये 2 मेन बड़े ग्रुप्स हैं. तो इसमें जो है आपको मतलब टू बी ऑनेस्ट अगर आपने सही टाइमिंग पे इन्वेस्टिगेशंस किए, सही सेट ऑफ इन्वेस्टिगेशन सही टाइमिंग पे किए, तो मोस्ट ऑफन हमें डायग्नोसिस मिल जाती है, मोस्ट ऑफन.
But say, for example, because we recently had a kid who investigated thoroughly right at the time of admission, sent all the metabolic investigation because the pH was 6.9 at the time of admission, base excess minus 2.3 or something. We knew that this is metabolic. We sent all the metabolic investigation. That everything was like ammonia was normal, lactate was normal, the sugar was normal.
What was the urinary ketones?
The urinary ketones, I think the ketones were positive.
How much?
I don't remember exactly. And the plasma amino acid and urine organic acids from AKU lab we recently got, they were normal as well. So the next step now obviously is some kind of genetic testing.
I would like to have a little more detail. It is difficult to just say which molecular test I will get done on this child, because assessment, there are some disorders.
No, I'm not asking a specific about a specific patient. Just generally, I'm asking.
Before अभी आपके colleague में से, I sorry I missed the name. किसी ने जो कहा कि वो एक अच्छी हिस्ट्री और एग्जामिनेशन के बेसिस पे थोड़ा सा ज्यादा क्लियरिटी आ जाती है, तो इस तरह के पेशेंट्स में हो तो सकता है, लेकिन ये कि फिर थोड़ा सा डिटेल हिस्ट्री चाहिए होगी कि किस वक्त होती है ये प्रेजेंटेशन, क्या ट्रिगर्स होते हैं, और फिर किस तरह से पेशेंट का रिस्पॉन्स आता है थेरेपी को. कुछ चीजें होती हैं अब जैसे देखना पड़ता है, लेकिन मैं अभी आपको सिर्फ ये इंफॉर्मेशन के बेसिस पे कि जी मेटाबॉलिक एसिडोसिस था, आपने एनाइन गैप का जिक्र किया नहीं है, ये सारी चीजें देखनी पड़ती हैं.
Right. No, I was not specifically asking about a particular patient, just generally, like, would you then
generally
go ahead for some
patient to patient vary करेगा sir.
Okay.
Right. Madam, another question is, if patient is in severe dehydration and is having persistent metabolic acidosis with anion gap of 20 to 22 in range, for how long we should wait to start workup?
Yeah, Warifna Jamal, I'm in a meeting. Can you call back in like half an hour?
So जो एनाइन गैप है इसकी डिफरेंट रेंजेस डिफरेंट जगहों पे आपको मिलेंगी. कहीं जो है इसकी कट ऑफ 17 तक लिखी हुई है, कहीं 24 तक भी गया है. सो मैं तो थोड़ा सा करती ये हूँ कि मैं एक स्पेसिफिक एनाइन गैप को, मतलब मैंने अपने आप को फिक्स नहीं किया हुआ कि मैं 21 को हाई एनाइन गैप कंसिडर करूंगी. मैं थोड़ा सा और चीजों को भी मिला के देखती हूँ कि व्हाट इज द ब्लड गैस स्टेटस, what is the other parameters कि जी lactate क्या है, urine के ketones क्या है, क्योंकि जैसे मैंने कहा कि एनाइन गैप मैंने खुद बहुत जगहों पे पढ़ा हुआ है, वो 14 to 16 तक भी रेंज लिखी हुई है उन्होंने, 12 to 16 नॉर्मल लिखी रेंज दी हुई है, कहीं वो 14 to 18 भी चले गए हैं, कहीं वो 22 तक भी लिखा हुआ मिल जाता है। सो इसका कोई स्पेसिफिक मेरे पास करेक्ट आंसर शायद है नहीं, तो मैं थोड़ा सा ओवरऑल मिला के देखती हूँ कि मेरे पास और बाकी पैरामीटर्स की क्या सिचुएशन है। और अगर जो है खास तौर पे एक पेशेंट है जिसमें डायरिया के बाद डिहाइड्रेशन हुई है, तो फिर उसका एसिडोसिस जो होता है वो और खास तौर पे अगर वो फेलियर टू थ्राइव भी है, तो फिर उसकी एसिडोसिस बहुत कम केसेस में जो है वो अंडरलाइंग मेटाबॉलिक डिसऑर्डर के वजह से निकलती है। लेकिन सेफर जो अप्रोच की जाती है वो ये कि अगर आप मेटाबॉलिक कंसिडर कर रहे हैं, तो यू स्टार्ट द वर्कअप। जो क्वेश्चन है वो ये कि हाउ लॉन्ग शुड वी वेट, वी शुड नॉट वेट, वी शुड स्टार्ट द वर्कअप। जैसे अभी आपसे पहले जो डॉक्टर साहब थे, वो ज्यादातर होता यही है कि वी स्टार्ट द थेरेपी। और ये याद रखिएगा कि आप लोगों के जो क्वेश्चंस हैं वो इस वक्त ज्यादा मेटाबॉलिक जो मेटाबॉलिक इंटॉक्सिकेशन ग्रुप की तरफ ज्यादा जा रहे हैं। हमने अभी जो HI डिस्कस किया था वो इंटॉक्सिकेशन ग्रुप की हेडिंग में नहीं आता, लेकिन हमारे यहाँ ज्यादातर मेटाबॉलिक डिसऑर्डर कंसिडर ही जो एक ड्रामेटिक प्रेजेंटेशन जो हम टेक्स्ट बुक में मेटाबॉलिक क्राइसिस का वर्ड पढ़ रहे होते हैं, हम उधर ही सिर्फ मेटाबॉलिक डिसऑर्डर सोच रहे होते हैं। और यही जो मेरा जो ऑब्जेक्टिव था कि हम उससे निकल के थोड़ा मेटाबॉलिक सोचें। हम सिर्फ मेटाबॉलिक क्राइसिस जब हमें एसिडोसिस मिले, हम तब सिर्फ उस वक्त ना सोचें। और मेटाबॉलिक एसिडोसिस स्टार्वेशन में भी मिलेगा, डायरिया में भी मिलेगा, डिहाइड्रेशन में भी मिलेगा। लेकिन अगर आपका पेशेंट जो है आप उसको मेटाबॉलिक क्राइसिस बिकॉज ऑफ अ मेटाबॉलिक डिसऑर्डर सोच रहे हैं, तो आप वेट ना करें, आप साथ साथ इन्वेस्टिगेट करें।
Right. Madam, Dr. Shabana is want to say something. Can you hear me, Dr. Shabana?
यस, आई कैन हियर यू। मैंने यही पूछना था कि जैसे बच्चे हमारे पास डायरिया के साथ आते हैं, मोस्टली नियोनेट्स, और वो इसी तरह सेवियर डिहाइड्रेशन एंड सेवियर एसिडोसिस के साथ प्रेजेंट करते हैं, और डिहाइड्रेशन करेक्ट हम कर रहे होते हैं और एसिडोसिस का हमें फिर ये नहीं होता कि हम पहले बाइकार्ब रिप्लेस करें, हम करते भी नहीं है यूजुअली। और 3 to 4 days लेता है एसिडोसिस थोड़ा सा ही इम्प्रूव करने में, यानी पीएच तो नॉर्मलाइज हो जाती है, लेकिन बाइकार्ब की रेंजेस वही 4, 6, 8 इतनी ही इम्प्रूव कर रही होती हैं। तो हम फिर रिलाई करते हैं कि पीएच कंपेंसेट होगी तो ओवर द टाइम बाकी सब भी ठीक हो जाएगा। तो लेकिन यही पूछना था कि कितने 3-4 days के लिए हमें वेट करना चाहिए कि हम बाकी
मैंने
वर्कअप
जैसे
भेजें?
कहा डॉक्टर शबाना, अगर आप मेटाबॉलिक डिसऑर्डर सोच रही हैं तो फिर आपको 3-4 days के बाद कुछ नहीं मिलेगा।
अच्छा, यानी हमें फौरन ही करना चाहिए?
हाँ, लेकिन वही मैं आपको जो पहले भी कह रही थी कि आपको पेशेंट देखना हो।
ठीक है जी।
अंडरवेट बच्चा है तो उसके तो रिजर्व है ही नहीं, डायरिया में तो उसका रिजर्व और चले जाते, उसका तो एसिडोसिस आपको जो है वो मिलेगा ही मिलेगा। लेकिन आपकी हिस्ट्री एक जो अभी आप हम वो थी कि हाँ, हिस्ट्री वाला पार्ट हमारे यहाँ कंप्लीट गायब होता चला जा रहा है। हम हिस्ट्री पे फोकस नहीं कर रहे हैं। हिस्ट्री के बेसिस पे असल चीज जो डायग्नोसिस जो हमारी जैसे मेरी जनरेशन थी, उसकी हमारी ट्रेनिंग का बेसिस जो था वो गुड हिस्ट्री थी, गुड फिजिकल एग्जामिनेशन था, फिर हम डिफरेंशियल्स बनाते थे। अनफॉर्चुनेटली अब मैं बहुत ज्यादा देख रही हूँ कि हम लैब्स देखने के बाद अपनी डिफरेंशियल बनाते हैं कि जी एसिडोसिस है तो हमारा जी वो मेटाबॉलिक डिसऑर्डर बन गया। हम उस एसिडोसिस का कॉज नहीं देख रहे कि आप खुद बार बोल रही हैं कि वो डायरिया के बाद आ रहा है। आप उस पेशेंट का वेट बताइए, क्योंकि देखिए आप उस पेशेंट की न्यूट्रिशनल हिस्ट्री का असेसमेंट कीजिए, उसको देखिए कि उस बच्चे में आपको जो है वो अंडरलाइन कोई ऐसा पैरामीटर मिल रहा है जो कि आपको जो है वो मेटाबॉलिक क्राइसिस। यूजुअली बच्चे कैसे होते हैं, वो बच्चे जो होते हैं वो नॉर्मल बच्चे होते हैं और वो फिर ट्रिवियल इलनेसेस के बाद मेटाबॉलिक क्राइसिस में जाते हैं। वो डायरिया और मेटाबॉलिक क्राइसिस में जाने वाले बच्चे यूजुअली उनका CNS इन्वॉल्वमेंट भी होती है, वो सिर्फ एसिडोसिस के साथ नहीं आ रहे होते।
Right. Any question from another participant? Most welcome. Sir Junaid, you want to say something?
No, it's okay. That's fine. I did everything. I think it's a nice discussion. if anybody else any questions, then of course go ahead. The reason actually, Bushra, we are focusing on the metabolic part because you know that it can present in many other forms, dehydration, and as you mentioned, all those stuff. But we as the neonatologists are very focused into the initial picture of the baby. So any picture which come to us with hypotonia, lethargy, and all those other than sepsis, we are thinking of many broad things, especially if we label the baby as HIE. Then we have to consider the metabolic part also, and to dig out more in the history or in the clinical examination. And if some basic test, if available in those centers, then we should do it, and then we'll see that how it is, how it progress. So that's why we are more focusing on that. Yes, Saeed, anything?
Right.
Or
No, sir, I think it was a very wonderful presentation today. Once again, I want to say thank you so much, madam, for such a nice presentation and for your precious time. So, inshallah, we will continue the session in next week. So, till that, once again, thanks to all participants and Sir Professor Khalid Haq and Professor Junaid Mohib Khan and rest of all our participants. So thank you so much. Allah Hafiz.
thank you.
everyone. Thank you for a lovely discussion. Thank you, Said, for having me. Allah Hafiz. Have a
Thank you,
lovely
madam.
weekend. Allah
Thank you,
Hafiz.
madam. Allah Hafiz.